My name is Usman Amin Hutiana. I'm working as an assistant professor of psychiatry at King Edward Medical University. Today I'm going to discuss a very interesting topic, and the topic is about the biopsychosocial model. In psychiatry, psychology, sociology, and other fields of medicine, this model holds a very central position. I'm going to briefly discuss what was the need, why this model was created, what are its current applications, what is fundamentally wrong with this model, and also a brief psychoanalysis of the person who developed this idea. Biopsychosocial model was basically formed as a result of criticism of much prevailing biomedical system. Biomedical model used to consider the patients just as patients, and it was thought that it was not enough to encompass unique properties which a human patient brings, namely the trust, the doctor-patient relationship, the empathy aspect, and all the soft qualities of the patient-doctor relationship. While discussing this event, we'll have to see the major changes in the past 100 years. Let's go back 100 years back. Starting from Kraepelin. Now, Emil Kraepelin was a biological psychiatrist. He was a student of William Wundt, who was an objective psychologist who started the behavioral cycle. Now, Kraepelin was all into biologicalism, biological dogmatism, and he was seeing the patients which were mostly psychotics. And he's also considered the father of biological psychiatry. He wrote the textbooks and he told us about the major illnesses, bipolar illnesses, psychotic illnesses, those kind of illnesses. 1900 onwards, the period started. There was some change, and that change was the rise of psychoanalysis in America. Now, psychoanalysis kept its hold for about 40 to 50 years, and in this time of psychoanalysis, new branches of psychology started, namely the behavioral sciences, the work of Skinner, Carl Rogers, and some other psychological branches. So now what happened was there was the kind of a struggle going on between psychoanalysis and the newer branches of the psychology. In those 50 years, starting from 1900 to 1950s, there were no appropriate medications. If there were, they were starting, and as we know, the clear antipsychotic chlorpromazine came in 1952. Lithium came a bit earlier, and tricyclics also came around that area. Before 1950s, the biological aspect of psychiatric illnesses was just as today we consider the position of genetics for a particular illness. So practically we could not do much about it. This led the famous psychiatrist Mr. Adolf Meyer. Adolf Meyer is a person who brought the concept of psychobiology. He considered that psychiatric illnesses are basically reactions to the life events. Now, Adolf Meyer also brought the concept that psychiatrist is basically a negotiator between the patient and the disease. So he is negotiating what can be done, what cannot be done. Now, Adolf Meyer also wanted to do this thing that he felt he should have some kind of solution to the biological problems, psychiatrical problems. There's a term called eclectic or eclecticism, which means whatever works. So based upon the much prevalent philosopher at that time, which was John Dewey, in the era of pragmatism, the American pragmatism, John Meyer used eclectic approaches. Wherever the problem was, a suitable solution was thought of. Now, the eclectic approach could be divided in different branches. For example, there was this dogmatic eclectic approach, which meant a very serious approach to the eclecticism. There was this pragmatic eclectic approach, that how we can help the patient. There was this value based, what the patient wants, what he does not want. Additive eclecticism, adding to different strategies, or the multidisciplinary eclecticism. Now, one a very interesting letter to the editor of American Psychiatric Journal was written by one of the young students, and they this approach eclecticism, which takes on any beliefs, is very dangerous for this science, because whatever somebody says and you accept it and gives it a place and you listen to that theory is not really the right answer. There must be hard-nosed dogmatism. We must have some kind of determinism in knowing about the multifactorial status of the psychiatric illness. And this person, who turned out to be Kenneth Kendler, the famous geneticist, who went and pointed out the genetics after 30 years. Now, this dream of Adolf Meyer was taken further by Mr. Roy Grinker. Now, Roy Grinker is a famous psychiatrist. He is just as important as Kaplan, Freud. He's in the same league. Mr. Roy Grinker produced about 100 professors of psychiatry, amongst which 18 held the chairpersonship. Now, Roy Grinker was very influential. He was, very interestingly, he was one of the last ex-patients of the Freud. He took 1 year of psychoanalysis treatment from the Freud, after which he said he did not learn anything. And even his wife said that no change has been observed. So Roy Grinker had a very close taste of the psychoanalysis. Very happy with it. At the same time, there was another person, George Engel. Now, George Engel was a physician who had a very good background in psychosomatics. So he did a lot of research and work in the psychosomatics related to gastrointestinal problems, and ulcerative colitis, and the gastric secretions in infants with fistulas, and all similar kind of projects. Now, George Engel was always very much impressed by his uncle, who was a clinician in New York and was well known for his clinical skills. George Engel had this desire all his life that he should do something about psychoanalysis, so he went and lived 5 years at Institute of Chicago under Joy Romano, a famous psychoanalyst and a psychiatrist at that time. But George Engel had some major issues. He was not, what I think is, he was not really oriented, or he could not really grasp the basics. And I'll prove why am I saying. Roy Grinker used these terms. He was in fact he was the first. We have this evidence. He was the first person which came with the precursor of this biopsychosocial model. And exact terms he used were biosomatic social. He used roughly these words. Biopsychosocial word was exactly coined by George Engel. And he said that I came up with this idea as somebody mentioned in one of my conferences. So it came from anonymous person. And what we believe is from certain sources that this anonymous person was none other than the Roy Grinker. So Roy Grinker bring out these ideas, and at the same time, George Engel in 1977, he read a paper at American conference. And he presented a case in which a myocardial infarction patient was presented, and who had been seen by the doctors. Due to his increased anxiety, the doctors could not get the permission for some test, and that resulted in negative outcome. Now, George Engel really believed that biopsychosocial model was the answer. There were some grave problems in eclecticism, which we just discussed earlier. So in Adolf Meyer times, for example, two things happened. Number one, there was this doctor called Henry Cotton, and who did a lot of he used to think that there's a focal toxin theory which said that mentally ill patients have the problem in their teeth. So he carried out a lot of whole teeth extractions to mental health patients. Walter Friedman was another person who carried out lobotomies for the same reason. So I feel that Meyer was unable to stop these kind of dangerous treatments because the eclectic approach could not stop anything. For it, anything goes kind of concept was going on. Coming back to George Engel, now George Engel, what he did was, at that time, von Bertalanffy was a German who came up with general systems theory. General system theory says that we have to understand an organism, knowing their different levels. For example, if you want to understand a gene, you will have to understand the working of a protein. If you want to understand a protein, you will have to know the understanding of a cell. If you want to know about a cell, you should know about how does that system works, and then an organ works. Now, Bertalanffy had this problem that he did not believe in the behavioral testing going on in psychology. He was not a very much fan of humanism, and he was very critical of these kind of approaches. However, he did think that personality could be the right approach to understanding of an organism. Now, Mr. George Engel, what he believed was that no understanding can come through art, science, or humanity. His psychoanalytical grip was so kind of faulty that he became the greatest critic of John Bowlby when he came with his psychoanalytical magnum opus of the object relations theory. So we see that George Engel brought up his biopsychosocial domain based upon the general systems theory, and now this biopsychosocial BPS model became an instant hit, like a very emotional slogan. It was popular with the psychologists, it was popular with the psychiatrists, the decreasing status of psychoanalysis, they also benefited from that. So you have to see that at that time, even there was a time when eclecticism was term used by allopathic doctors as well as homeopathic doctors. It was kind of a win-win situation for both of them. It was only after the Flexner's report, the famous medical education report, Flexner saw that all the medical colleges were deficient in some kind of way, and a university. After this Flexner report, the eclectic tag was going down, and the biopsychosocial model made the doctors, because everybody feels safe and their respective positions. So BPS, biopsychosocial, served a very important thing at that particular time in 1970s and 80s. Now, what happened? Why this thing has to be changed, and why it is such an important issue? The biopsychosocial model promised few things. It promised hope for research. It created a framework for understanding. There was this promise of harmony, promise of delivery system, but this did not happen. A lot of people have criticized it purely on the basis of its status as a model. What it is said is that it is not a model, it is just a theory. Biopsychosocial model does not meet the criteria of a model, which means an actuality of a theory. So whenever there is a model, what is told is something about the variables, their relationships, the error mistake, and we see that we don't have a clear idea how the biopsychosocial model tells the relationship between biology, psychology, and sociology. We never know which one to use when, how much to use, how to combine. The analogy which comes to mind is that an ingredient list. It does not tell about the recipe, or it's like a buffet where you go on and you mix 3-4 dishes together and you basically spoil all the dishes. So we will about that it is much better to have the dishes in their pure form. It is much better to have the psychological methods in their purity rather than just mixing them hodgepodge. There is some research evidence to prove that pure form psychological therapies are more effective. In 1978 is the biological revolution came back. After the Kraepelin biological stance, now psychiatry came at the forefront. RCT's randomized control treatment came into full action. A lot of biological compounds came into practice with very good results. So now suddenly sociology and the psychology were not very interesting. A lot of research came in the favor of biological methods. So now the case is then in our practical purpose in the developing countries like Pakistan or India, for all purposes, we have very less psychiatrists, we have very less psychologists. This reserve force should be used in a most efficient way. And my 15 years of training and working at different departments, what we see is that there is this traditional dogmatic approach coming up with each conference, each case, each presentation, with this traditional approach of biopsychosocial model. Everything does not have to be kind of dissected with this biopsychosocial model approach. We know now that some illnesses are purely psychological basis and they need psychological help, like for example conversion disorders. We know some of the illnesses are purely biological, pure medicines are needed at least at the starting position, and then we can also use some part of the medication. And some things have need some kind of mixed approach. One of the biggest problems with the biopsychosocial model is that clearly George Engel was again against one of the key concepts of psychiatry, and that concept is, you must be familiar with the basic concepts of psychiatry, where it talks about the two German terminologies. First is called Erklaren, and the number two is Verstehen. The Verstehen means an understanding, the meaning. It basically means to knowing an actor as he is experiencing his experience on the stage, not as we are experiencing him objectively. So in short, it's about the subjectivity, and the Erklaren is about the objectivity. In disease terms, it means the total outcome, the symptoms, the course, the treatments, the outward form. And Verstehen means how having the symptoms means for the patient to understand what he's going through, and that kind of story. So George Engel did not believe in subjectivity. This is one of the major problems with his theory are. The main philosophical force, and in those times, probably after the George Engel's time, proponents in philosophy was a big name called Wilhelm Dilthey. Now, Wilhelm Dilthey was somebody who gave a lot of importance to this subjectivity phenomena. So she thought that the Verstehen is the main thing without which psychiatry cannot exist. She was Dilthey was a philosopher. So he was a philosopher who took the place of Hegel after he died. Now, Dilthey has this affinity towards psychology in a very subjective way, and he was not very happy with how William Wundt brought this objective force to the psychology. Now, what is happening in recent times in, for example, John Hopkins, the psychiatrists like Paul McHugh, what they are doing is they have started this new model which also could be called a biopsychosocial model 2.0, or much better, what they are using is they use this new strategy called method-based psychiatry. Now, method-based psychiatry, for that they use a term called methodological consciousness. What they're saying is that we need to be aware which method is the most appropriate for a given psychiatric patient. All they're saying is that we have to make a priority how to approach a particular case based upon our evidence. A little bit about evidence-based medicine over here. Now, we know that evidence-based medicine is again very biased towards the medical models, and it does not really do justice to the psychology or the different kind of psychology. So there is a lot of debate how different studies are shot down, why drug studies are more in number, because psychological studies are very expensive and difficult to conduct. So research has to be seen again with a very, very, I think, clear, observant, and pragmatic mind. Cochrane is doing a little bit of help for us in this division. Coming towards the end, let me re-emphasize that right now we are not even clear how to use the definitions, basic definitions of health and illness. WHO uses the definition that health is complete state of where the person is in the complete of his biological, psychological, cultural, social, and spiritual status. This definition is very comprehensive, but unfortunately completely useless. No one tests themselves whether they are completely healthy or how much they are ill using this definition. So we need to define the definition. We're still struggling knowing the concept of the illness. Psychosocial, psychosomatics. Now, psychosomatics is very interesting. The psychosomatics deals with this problem of the illness, where you have some kind of symptom, but the symptom is not the illness, it is the belief in the symptom. So when we take this symptom to the doctor, how he does, what he makes of the symptom, what we believe about it, is based upon a lot of other soft factors like patient-doctor relationship, our own belief about the illness, our illness behavior, our own personality, our own prejudice, some other cultural factors. So this was a small broad line framework why I think biopsychosocial model has to be replaced by the new method called method-based psychiatry. Some of the students raised this question that why, or is there any other competing force which can be considered? Yes, William and Engel, when he was being impressed by his uncle, at the same time, world clinician Osler was always already there. He had already set his example. Now, Osler used the terminology of biomedical with humanism. Some of the factors which we bring to the human dealing is just a part of the humanism. It has to come through a biopsychosocial scope. We can deal with our medical etiquettes. We can bring the Osler humanism to our biomedical model. Qualitatively, a good clinician, he will deal with those issues which we bring under biopsychosocial model in his routine about any given illness. Practically in developing countries where the average time with the patient is about 5 to 10 minutes or 10 to 15 minutes, we can only do the biological version. Now we do want that all the portions, biological, psychological, and social, should be met. But practically what has happened because of this biopsychosocial model, now the psychiatrist is confused. Is he a psychiatrist? Is he a psychologist? Is he a sociologist? These fields are so diversified. We cannot wear all the hats. One of the problems with this model is that we have been unable to harness our full force expertise in the field We are not really good in biology. We are not really well versed with the biological compounds, drug interactions, their macromolecular, messenger level problems, you know, concepts of other illnesses, other medications, other treatments, their biological influence on psychiatry. Now, we as a specialist, we have to understand that the limitations of a human mind, we take on our plates, the more challenge is increased. This is one of the view based upon very authentic criticisms by world famous psychiatrists, some of the well known names like McLaren, Pelgrim, and Nassir Ghaemi, who at length discuss about the rise and fall of the biopsychosocial model. He talked about eclecticism, and method based psychiatry could be the next answer. If you have any questions regarding this model, please post in the comments below. If you like something about this video, I will hear from you. If you want me to talk about some other issue, I will like to talk about. On mind is I will next video I would like to talk about how the mind-body dualism has created a fraud in psychology and psychiatry, and what could have been the other possible ideas. If you feel excited about this idea, let me know. I will try to develop it. Thank you very much for your patience and listening. Goodbye. Have a good day.